Ladies and gentlemen, welcome to today's webinar hosted by the Supportive Care Coalition and the Catholic Health Association. Today's presentation is titled Palliative Care Social Work and Chaplaincy During the COVID-19 Pandemic, presented by Dennis Gonzalez, Jennifer Levi, Carrie Meyer-McGrath, and Sedona Montalongo. Before we get started, I'd like to mention that today's session is being recorded and you are currently in a listen-only mode. You will be receiving an email tomorrow with access to the recording to listen to on demand. A large portion of today's webinar will be a question and answer period, so please use the questions panel on the right side of your screen to begin submitting questions at any time for our panelists to discuss. We also encourage you to share what you are doing to support healthcare staff during this stressful time, as well as links to resources that you have found helpful. We will share them after this session on the SCC website's COVID-19 resource page. If you experience any technical difficulties during today's webinar, you can click the Help tab at the top of your control panel or ask me a question directly in the questions panel. Now, without further delay, it is my pleasure to introduce your moderator for today, Denise Hess, the Executive Director of the Supportive Care Coalition.
Thank you, Brianne, and welcome everyone to today's webinar presented by the Catholic Health Association and the Supportive Care Coalition. For those of you learning about the Supportive Care Coalition for the first time, the coalition is a partnership of Catholic healthcare ministries from across the U.S. dedicated to advancing excellence in palliative care through ongoing advocacy efforts at the local and national levels, interprofessional education, resources in healthcare ethics, and the integration of spirituality in palliative care practice. Coalition members have complimentary access to monthly webinars, numerous resources on our website, and a community of like-minded learners from all disciplines represented in palliative care. And as Brianne mentioned, we also have added to our website a page of COVID-19 resources. These are updated on a regular basis. You can see them here for those of you who are logged in on the computer platform. And I would invite you to check back on this page regularly to see the new resources that we add for your benefit and assistance. And since caregiver well-being is also very important to us, especially in times like these, we also want to introduce you to our caregiver well-being page. You can see the header there at the top of the page. This is where you will find numerous short reflections, meditations, and readings designed to ease the way for all people taking care of patients and making difficult decisions during this pandemic. Again, check this space regularly. New reflections are added daily. And on that note, I would like to begin our time together with a poem. The poem is titled The Miracle of Mourning, and it is written by America's first national youth poet laureate, and her name is Amanda Gorman. And while I will be reading her words this morning, I would invite you to explore this poem and watch her read it in a version recorded by CBS News you can find on YouTube. So The Miracle of Mourning by Amanda Gorman. I thought I'd awaken to a world in mourning, heavy clouds crowding a society storming. But there's something different on this golden morning, something magical in the sunlight, wide and warming. I see a dad with a stroller taking a jog. Across the street, a bright-eyed girl chases her dog. A grandma on a porch fingers her rosaries. She grins as her young neighbor brings her groceries. While we might feel small, separate, and all alone, our people have never been more closely tethered. The question isn't if we will weather this unknown, but how we will weather this unknown together. So on this meaningful morn, we mourn and we mend. Like light, we can't be broken, even when we bend. As one, we will defeat both despair and disease. We stand with healthcare heroes and all employees, with families, libraries, schools, waiters, artists, businesses, restaurants, and hospitals hit hardest. We ignite not in the light, but in lack thereof. For it is in loss that we truly learn to love. In this chaos, we will discover clarity. In suffering, we must find solidarity. For it's our grief that gives us gratitude, shows us how to find hope if we ever lose it. So ensure that this ache wasn't endured in vain. Do not ignore the pain. Give it purpose. Use it. Read children's books. Dance alone to DJ music. Know that this distance will make our hearts grow fonder. From a wave of woes, our world will emerge stronger. We'll observe how the burdens braved by humankind are also the moments that make us humans, kind. Let every dawn find us courageous, brought closer, heeding the light before the fight is over. When this ends, we'll smile sweetly, finally seeing in testing times we became the best of being. And so today we are especially excited to welcome our 4 panelists to lead today's discussion. Dennis Gonzalez, the Senior Director of Mission and Innovation and Integration for the Catholic Health Association. Jennifer Levi, a social worker with Palliative Care Connections at Providence St. Joseph Health. Carrie Meyer McGrath, Director of Mission Services for the Catholic Health Association. And Sedona Montalongo, a palliative care chaplain with St. Joseph Hospital and Medical Center with Dignity Health. The plan for our hour and a half together today is to have our panelists address several questions that came from all of you, our webinar audiences. And as time allows, we will end the webinar with live Q&A questions, fielding questions that you all post into the questions panel on your dashboard. With each question, we will begin with our 2 on-site at the bedside clinicians with Jennifer, our palliative care social worker, and Sedona, our palliative care chaplain. And they will be followed by our 2 organizational cross-system level leaders, Carrie and Dennis from the Catholic Health Association. And as we go back and forth between the questions again, as Brianne mentioned, I would invite you to type in your own questions, share your own resources, and we will push those out to you all via the chat box. So with that, let's begin with our first question. Really the primary palliative care intervention, the goals of care discussion. And the questions that came from our audience around this are all of the new challenges presented to chaplains and social worker members of palliative care teams, having to do what is a familiar and, as I said, primary intervention, a goals of care discussion, but conducting that under unprecedented circumstances with families who aren't able to see their loved one, the patients who aren't able to see and feel supported by their families, often using platforms for telemedicine and telehealth. So the question that I will first pass to Jennifer and Sedona is, how can we support and advocate for our patients and their loved ones in this new situation? Sedona, you are muted.
Thank you. I would like to first thank you, Denise, and the Supportive Care Coalition for having this webinar on such an important topic. And it's really important for those of us who are at the bedside to know ways to support our patients and our families, especially during this really difficult time. So thank you for hosting this for us and inviting us on. So this is a really important question and something that I know Jennifer and I have bumped up against, especially in the last couple regarding goals of care conversations in the midst of COVID-19. As we know in palliative care, goals of care conversations can be challenging in many ways, just because we're asking and inviting our patients and families to think and wrestle with really critical things that are going on in their lives. And so just at baseline, it's a challenging conversation to have. And now coupled with this pandemic and the restrictions that hospitals have placed in order to keep us all healthy, and it's an important thing for them to do, that has caused added distress on our patients and our families and on our staff, because we're asking families to make decisions for their loved ones if they're not able to make decisions for themselves, without having actually laid eyes on their loved one. Sometimes patients have been in the hospital for weeks because they are so critically ill, and they have been declining. And now we are having a goals of care conversation, not even in the typical way we would like to have goals of care conversations, where you have a sacred space, you sit down, you do the things that you do in a conversation, tell me about your loved one, all those things. We're now doing it sometimes in a lobby, in a corner, in a place that is not conducive to a conversation. Many times these are happening over the phone. And we're asking these families to make critical decisions about their loved ones when they haven't even seen the decline or seen their patient, their loved one, which is really very challenging. And I think what is happening and what I'm noticing is that people are actually opting for more aggressive treatments when the patient is clearly declining and the prognosis is very grim. They're still opting for more aggressive treatments because they don't see their loved one. And it's very difficult to ask them to free them from life support when they can't touch them or see them. And so that's one of the challenges that I'm finding, and perhaps Jennifer can add on to that as well, but one of the challenges that we're finding. So how can we support them and the staff during this time? One of the things that we do, and perhaps there are other things that you all are going to shout out to one another that we can learn from, is something called medical memory. Medical memory is an application that you can download on the App Store. And it was actually created by one of our physicians at St. Joe's because his father was critically ill, and this was a while back. And he was not getting the information from his father the way he had hoped. And so he created this application called Medical Memory. And what you do is you download it, and it's HIPAA compliant, which is the main, concern for all of us. So it is HIPAA compliant. And the nurse or the physician or the chaplain or the social worker is able to record a message, video it with the chaplain, with the patient, and send this recording via email to the loved one. And this is really helpful because I have used medical memory when I've asked the priest to come in to have a sacrament of healing. I will record that. I will send it to the family. I will record prayers with the family and send that. The nurse can record the update for the day, send that to the family. Not only is this helpful for the family to see the loved one and know that they are not being abandoned, because this is a critical issue for our families, is the feeling of abandonment. So for them to see that we are at bedside, to see that we are still there, we are doing our work with the with the patient. And this has been very, very helpful. Families very much appreciate it. The good thing is that once we have hit send on the recording, you can put this on your phone, obviously, and we hit send, we are never able to see that again. The family can, but we are never able to pull that up. So it is very much a HIPAA compliant method of recording. So that's one of the ways that we've used at the hospital, one of the ways that I found very, very helpful. And then, of course, there's the telemedicine. One thing that I found very important is supporting our staff during this time, because it is a very stressful situation. And sometimes staff get very frustrated that families are making bad decisions for their loved one. And it's having to have gentle and loving conversations with staff, reminding them that this is very difficult and not the normal situation for our families. And we're asking them to make life and death situations without even touching or seeing their loved one. So it's those gentle kinds of conversations that we support our staff during this time as well. And so the goals of care conversations are definitely more challenging in asking them to make decisions that are just a little bit out of the too hard box for them. Jennifer, what would you like to add?
That was great, Sedona. Incredible suggestions. I think I just want to say to everybody on this call, there isn't more of an important time for palliative care providers. I feel so called and pulled to our work right now more than ever. I think as a field, we have been so full of creativity and change as we've developed our profession over the past, 15 plus years. And right now is a time that this innovation and creativity to serve individuals and the people that care about them well couldn't be more important. And I feel like we are the ones that can offer this when we stand next to our colleagues that are so burdened with the pressures of the care and the complications that come with PPE and all those things. We have this opportunity to find creative ways to serve individuals and their families in ways that we've never faced before. And so, yes, all these ideas about technology and innovation around increasing our comfort with video and phone conversations, this is certainly new ground for all of us, and to support each other through paving the ways for our the patients and the people that care about them to be able to have meaningful time together in different kinds of ways. We have the skills and the ability to do this. I have a lot of passion around this because I see a lot of our colleagues being furloughed or having to take time back, and it's just confusing to me because particularly spiritual care and emotional care, this is a time where those types of skills couldn't be more important. And I don't have a lot of specific interventions. I mean, I think Sedona covered a lot of what we're doing. I just want to kind of call to our community that this is our time. This is our time to step up. And I would love to hear what Carrie and Dennis have to say about that as well.
Thank you, Jennifer. Again, I want to thank Denise and the Supportive Care Coalition for partnering with the Catholic Health Association for this whole series of really meaningful conversations. What comes to mind for me when we think about supporting and advocating for our patients and their loved ones in this situation has a lot to do with meaningful and living policies from a facility and a system level. And within that, it's making sure that mission and spiritual care, pastoral care are at the table in these conversations. What I mean by meaningful and living policies, things that are crafted with the whole person in mind. Of course, we are making sure that we want to keep our coworkers, our associates, our caregivers safe and healthy and mitigate the spread, but writing things with a language that has a pastoral sense, with language that is human and that constantly affirms kind of the whole person care. I think also, given how quickly everything is changing, we support and advocate for our patients and our families when we are willing to reassess what's going on in a real live way to meet what is the need of the situation. A couple of pragmatic pieces, what this looks like across a facility might be, if you have someone manning the door, so to speak, or if you have someone who's letting people know that where they can go or if they can visit, make sure that the person who is running the door has someone to call and say, here's the situation, and not necessarily that anything's going to change, but just that all of the individuals would be heard. so that it's not one person making any sort of decision, but that the policies enable everyone, keep them safe, and say this is what we're doing, this is why, and that's what's important. I think the supporting and advocating is also, so many things are different, but what chaplains and what palliative care providers and social workers are able to do is to say, these are the things that are the same, that we affirm the whole person, we affirm the loved ones of this person, and we're here with you, struggling through that difference. So when I think and when I hear at a system level conversation about supporting and advocating for patients and families, it really does kind of look at how are we speaking about what we're doing, how are we monitoring our policies, and who is at that table as kind of we're crafting those policies. Dennis, I believe you had some other thoughts.
Thank you, Carrie, and thank you to all of you for joining us, and thank you to the Supportive Care Coalition for co-sponsoring today's call. I must comment, I really appreciated and loved that opening poem by a young lady named Amanda. That was a beautiful setting, staring out the window and admiring the morning as you were reading that. To build a little on what Carrie spoke of, in terms of policies that are being implemented, obviously to protect patients and families and staff, and when you are not able to physically lay eyes on your loved one, it would be very hard to bear that. I think if any of us imagine being in that situation, it is an unbearable thought. What I would comment on from my experience as a mission executive is that there really needs to be a designated leader who the chaplains, the nurses, the palliative care workers, the family knows that they can go to for an answer, for a response, for action, for clarification. This is where the leader stands up and takes responsibility and is the person who can answer questions, can remove barriers, can listen and allow not only staff but families to share their grief, share their frustration, and share their feelings, as uncomfortable as it may be. I also want to mention and comment on something Jennifer said about the essentiality of caregivers beyond physicians, nurses, and respiratory therapists and anesthesiologists. In a Catholic health system, and Carrie and I represent the Catholic Health Association, spiritual care, spiritual healing is core to who we are. And chaplains and others, social workers, mental health workers, they provide spiritual healing. We are unable at that point to heal the body, but we can certainly tend to the spirit and to the soul. And so once again, I think the leadership in facilities are called upon to recognize that these providers, whether they're chaplains or social workers, palliative care folks, they are essential. They are essential to the mission. They are essential to our existence as a faith-based organization in our case. And therefore, when decisions are being made, and I'm referring to budgetary decisions, that they should be considered essential. The bishops of the United States wrote a letter to the Congress a few years ago, and in that letter, I'll never forget, it was a very poignant line where they indicate that budgets are moral documents. Show me what you spend your money on, and I'll tell you what you value, is basically the thought. And so in times of crisis and financial strife, which is what many of the systems across the country are experiencing, that is the time to say, what do we value? Why do we exist? What's our mission? And therefore, what is essential? And my hope is that we will see providers who are walking with families at the end of their lives in this crisis will see that that is why we exist, and that is of value, and therefore make those decisions. After all, that is what Pope Francis tells us servant leadership is. And so I see it as a great opportunity for leaders to rise up and stand up, and of all times in a crisis, to demonstrate what the mission is and why we exist as a service.
Thank you so much, Jennifer, Sedona, Dennis, and Carrie. As we navigate to the next question, Dennis, I'm really glad you raised the issue of this essential, non-essential language that many of us in the social work and chaplaincy disciplines are hearing right now. And I think there's many layers to this next question, but that is one of the layers. So this question is about the kind of damned if I do, damned if I don't moral distress many caregivers are feeling. They feel a duty to be there and be present and serve and follow their calling to care for patients right now. But on the other hand, with shortages of PPE gear, they're also worried about their own safety. And then I would add that extra layer you raised, Dennis, of worried about communicating their essentiality or not communicating their essentiality by the presence or lack thereof. And then there's this other technological issue that Sedona and Jennifer addressed in question 1 of how do we work with this technology in a way that still communicates authentic, compassionate presence. And I'll just throw in there one other tiny bit, Sedona, when you get to this question, one of our audience members did just ask you to say just a tiny bit more about the medical memory tool and just kind of how it's been accepted and used by different disciplines in your setting. So with that, I will call back Jennifer and Sedona. And thank you.
Sedona, do you want to go ahead and respond to that first?
Sure. So the medical memory app is actually widely used in our hospital when the COVID crisis really started to hit. We had several staff members go to each of the units and basically teach us how to use the app. It's really not difficult, but at first it's a little, can be a little intimidating in the sense of am I hitting all the right buttons? But it's pretty easy. And so what is done is what we have done is we put a sheet that says medical memory and that they are registered. So some staff will register the patient already, which there's several questions. You have to put in the patient's name, birthday, make sure you've got the right patient, and the loved one's email address. So once they're registered, any provider can go in, pull up their phone, do the recording, and hit send because they're registered. If they're not registered, that's where you will be filling in all this other information, but it's really not difficult. So it's widely known within our units. Many of our patients are already registered, and so it's been very, very helpful, and families really do appreciate just seeing their loved one, seeing that they are being prayed for, seeing that we are holding their hands, giving messages of "Mom, I love you," things that the family member had wanted us to say. But the technology piece, once you do it once or twice, it's very easy to use. The things we just want to make sure we're doing is keeping our phone very, very clean. Those are the things that we do anyway, but we are taking our phone in and using it. So, just those kinds of things that we need to be very aware of. But it's a very easy app. I do want you to know that if you're going to use the app and you get permission from your hospital to use it, please be sure that you download the Medical Memory Provider app. There's 2 apps on there. You want the Provider app. And then you will have to put in your hospital that is allowing you to use this. So I think that other hospitals have begun to use it as well. I'm not positive on that, so don't hold me to that, but I've heard through the rumor mill that others are using it. So if you have any other questions, please go ahead and put it in the chat box, but our hospital has been very, very proactive in it.
Thanks, Sedona. So just in terms of moral distress and technology, I think that in this question, there's a lot kind of packed into there. And the first thing I just want to acknowledge is I think that all of us are carrying an extra load of concern and worry from our own personal lives that varies individual to individual. And I think that, during the early weeks of this pandemic, there was so much uncertainty about what we're supposed to be doing, what is safe. And there was a lot of confusion and mixed messaging among interprofessional teams, healthcare systems, media, and also kind of what we're conveying to families. I think during that time, it heightened the moral distress. I think over time, there's been a little bit more consistency in messaging out about how to keep ourselves safe. And the way I think about this just in my practice always is that if I don't feel safe, if I don't feel grounded, if I don't feel like I have the support I need, there's no way that I could practice in a way to support individuals and families. So this is a time when I think we need to seek out new and additional ways of coping. Looking to our team, this is a group of palliative care trained professionals. When we look at our colleagues, we have an incredible network of resources amongst each other to find ways to support each other through this. People outside of our field, outside of healthcare, I don't think can quite understand the heaviness of what we're carrying with us each day. And so I think that I find strength and unity and commitment within my own team. And I feel like now is the time that we need to lean into each other to support each other. And again, it's true, we haven't been trained to provide care in this kind of way. And I think one of the things that I've always loved about palliative care is that we've done really incredible things around serving individuals and the people that care about them in rituals in ways that are unique to the hospital setting. This really is no different. We just need to find ways to do it through our masks and through our gear. And I think that if we look around with each other and support each other in ways, we can find new and unique ways to support the individuals and families that we care for. And Sedona, was there more you wanted to add to that?
I thank you, Jennifer, for all that. The leaning on the team at this time is really important, and it does, at least for me, as I'm hearing from you, keeps me sane because we're all going through this together. The part of the question where it says depersonalizing, it is hard. I will agree wholeheartedly that providing spiritual care and goals of care conversations through the phone is always going to be challenging because you don't have that, you can't assess the person's body language. You can't see those things. It does make it more challenging. And also using our gear and putting the mask on and all that we do. I personally remind myself that if we don't go into that room, no one else is going into the room. They don't have their family going into the room. So we are their family at this point. And so while it's challenging for me, I have to remind myself and sort of, buck up and remind myself that I am the face of their family at this point. I'm the one that's bringing messages. I'm the one that's helping with that, along with the team, not just me, but that's what we do. So we all, as spiritual care providers, as social workers who are working with all the emotional pieces that you do, we are the stand-in. We're the proxy for their family. So that helps me to bring it more home into my heart space instead of, thinking about it as a block. I look at it as more of this is something that is beautiful for them as well as for me in a different way.
Thank you so much, Sedona and Jennifer. If either of you are you good? Should we call back Dennis and Carrie? Okay, great. Dennis and Carrie, if you want to join us back. Thank you.
Thank you. That beautiful response. I want to just comment that, in my role, I am not a chaplain or a palliative care professional. However, I have been privileged in my previous role. I worked for a pretty large Catholic health system for about 12 years as a mission executive for most of that time. And I was privileged in those roles to oversee or support the spiritual care departments as well as the palliative care programs in those two regions of that health system. And if I learned anything other than that they are amazing, remarkable human beings, it was that if anybody does, they recognize in their hearts the sacredness of the service that they are providing. They personify what it is to appreciate the dignity of the human person. They are exceptionally well trained. And I have seen chaplains, social workers, palliative care professionals work under the most challenging of circumstances with families, with patients, with staff and physicians and others that are highly stressful, highly charged, highly emotional, very difficult situations. So what I would say in answer to this question is, you've been prepared for this. You are prepared for this. This is what you've been trained for. Don't discount that. Remember why you signed up. And I personally have seen you perform remarkably under very challenging circumstances. And yes, this is a challenging circumstance. But if anyone is prepared and trained for this, it is our palliative care teams. The other thing I would mention is I'm reminded of something that one of the sisters told me, told a group of us at a meeting. And her name is Sister Dot, and she's rather famous. And she said, if I could give you all one piece of advice, it is whatever happens, don't forget to refill your well. It's a very simple phrase, but being from Santa Fe in the Southwest, I kind of know that wells can run dry, in the desert. And it's a beautiful image that all of us, especially those that are working under those challenging circumstances with patients and families at the end of life, you're human as well, and you need to refill your well. What is it that refills your well? Well, only you will know. But whatever it is, please do it. And leaders hopefully need to recognize the need for these folks to have the opportunity to refill their well, whatever that may be. And we'll talk a little later, but we are seeing amazing efforts across the country by health systems to support staff in the ability to refill their well. And so that's what I would comment on. If anyone personifies what it is to serve under these circumstances, it is palliative care professionals. You've been trained for this. You are ready for it. You've been doing it for years. And a reminder to do self-care, refill your well, take care of yourselves as well. Carrie?
Yeah, thank you, Dennis. Just an underscore of some of the things that Dennis said and that Jennifer said as well, is that to some extent, or to a large extent, both personally and professionally, that last exclamation point, "This is not how I was trained," help, is what everyone is going through. And trying to forge a new way is uncomfortable. There's no playbook for this. But I would, like I said, Dennis just said, the imagination and the creativity that we're able to bring and that this discipline has always brought to healthcare are going to show up here in the same way. One pragmatic piece, though, that struck me as well, is I'm thinking through, the forced move to virtual care for some places, the forced move to audio consults. For a long time now, many of our systems have known that's where we're going and have been, not completely like we're doing now, but have been making those moves. I think of the virtual care that's been able to be offered in rural and very isolated settings, and what that has been able to do for those patients and loved ones in those settings. And so, not to be a Pollyanna at all, but I'm really enlivened when I think about what creative practices, what an amazing opportunity and crucible this is for understanding what are the successful practices of spiritual care, social work in this space, in the telehealth space, and that trusting that the presence that spiritual care holds is going to come through. There was a question from the audience about the provision of sacraments in the telehealth space that I've been asked to attend to, and it's a really challenging one. In the chat box link, you should have a link to the CHA website, and there are two resources from in pastoral care answering this question. The first is kind of a reminder about what are some provisions around the sacraments, and the second is a FAQ on more of the practical realities around the provision of sacraments in this space. NACC, the National Association for Catholic Chaplains, and CHA worked on these resources together, and they have been reviewed by the USCCB. So there's a level of gravitas there. I know that we've had a lot of patients who have been concerned about, my loved one can't get last rites. My loved one can't necessarily go to confession in the same way. And that's been a real form of spiritual distress for those individuals. In that space, I think there are some great statements that have come out from Pope Francis, some great affirmations that we have about who God is and how God works in the world, and the intention behind our spirituality being enough in these really extenuating circumstances. And that's always been a part of our tradition. And so I would encourage people to lean into that space and to look into those resources, because they are very pragmatic, very granular, and without pulling out specific things. We could go through the whole thing here, but they should help you and guide you. So just that affirmation that there's no playbook. I could say, this is not how I was trained to parent. This is not how I was trained to be a spouse. This is not how, this isn't how any of us were trained. But that creativity that you bring is really going to come through, and we've already seen it coming through. So, Denise?
Thank you so much. Yeah, thank you, Carrie and Dennis. Very important points to highlight, especially that we are, no matter what our role is, professional or outside of work, we are all reinventing ourselves at this moment and drawing upon our creativity. So the next question I'd like us to move on to, again, is a multi-layered, complicated question about complicated grief, about the potential for trauma. And specifically, this question is focusing on those issues for persons with serious illness and their loved ones. Just as a quick preview, the next question, we will look at these same types of issues for caregivers, for those working in healthcare and caring for the seriously ill, and the secondary vicarious trauma they might be experiencing. So focusing first on persons with serious illness, their loved ones, their families, tell us, and we'll start again with Jennifer and Sedona, tell us what you're thinking about, what you are anticipating about what grief might look like as a result of the unique circumstances the pandemic has brought to us. Specifically, many of our audience's members have referenced the fact that it's just not possible to say goodbye in the normal ways we have facilitated that before. And then again, secondly, since this is a complicated question, a lot of awareness around the potentiality for trauma and what signs should we be looking for and how might we be using that awareness to inform the care we provide.
So thank you. I think this is a fantastic question, and I want to take it a little bit upstream. I think that right now with our outpatient palliative care programs and with our primary care clinics that, are experience a little bit of reduction of patient care, this is an opportunity for us to start reaching out to individuals and the people that care about them that are at high risk for hospitalization and death, and proactively start to do this anticipatory grief work. There is a huge void here where people are scared to seek hospitalization. They're scared to call their physicians, and nobody is reaching out to them. And so I think that right now, when I think about trauma-informed care, when I think about how grief can be complicated, we have a huge workforce right now that is being underutilized. And so if we could reach out to these caregivers and have them to start to communicate with their patients, their families, and to start some of this work. I think in particular about marginalized communities that maybe don't have a lot of support or have increased experience with healthcare trauma. This is an opportunity for us to lean in before we get to that point where somebody's in the ICU on a vent and we're talking about death. So when we talk about trauma-informed care, it is a lot about giving a heads up, forecasting, preparing families. And right now we have a huge opportunity to lean in and do that because we have people available and ready to do the work. And Sedona, I would love to hear more about your thoughts around this as well.
This is, I believe, one of the very, very big things we have to be aware of moving forward. I think that after all is said and done and everything is calmed down, that the complicated grief that we will be encountering from people is going to be really, really big. I was speaking to a husband of 54 years yesterday whose wife is, they're going to free her from the ventilator on Saturday, and he has not been able to be with her or see her for 2 weeks. This is another one of those stories. Now, I'm planning a funeral for someone I haven't seen and will not see, and I'm planning all of this. This feels like a big void, like it's not even really happening. And so I could just imagine at that time the grief that he and his children will have, knowing that they're planning a funeral for a body that they don't even really recognize as dying. And so that's just one of many, many stories that we know about in this situation. And so I can bet a lot of money that we will be very inundated with complicated grief in the next year, just because of the way that people are dying and the way that people cannot grieve. Families, I believe, going to be a big impact on abandonment issues. I wasn't there when my loved one took his or her last breath. I wasn't there to be able to make decisions. I wasn't there. And so it's not only the complicated grief, but it's abandonment that I think will be woven into that. That's going to be a very challenging thing for our families and loved ones. And so the traumatic stress that will be woven in with that as well is going to be quite large. So I'm just concerned about that.
And I just have a few more things I wanted to add. Thanks, Sedona. I agree with you. I think that we are consistently seeing signs of how grief is going to be complicated. I think probably every single death experience we've had in the hospital, COVID or not, we see that this is going to be a tough road. And I think right now is also a good time for us to lean into our hospice bereavement partners, checking in with our local hospice bereavement teams and seeing what they have the capacity to do in terms of reaching out and supporting the folks in the community, what kind of groups can be offered. And again, spiritual care providers and social work providers, we have unique training experience that this is an opportunity for us to lean in and provide some guidance, support, and facilitation for these communities of folks that have this new level of grief that we haven't really experienced before. So again, I know I keep talking about this. Part of it is about, like, for us to advocate for job security and opportunity and looking to the future. These are opportunities for us to say we have the skills and the training, the capacity and the ability. We need to serve this population not only before the death, but also after the death. And what are our hospice partners doing, and how can we support them as well?
Yes, Jennifer, I think that's really, you raised some great points. One of the parts of this question is how can I help prepare families for the complicated grief? And I think one of the ways that we can do that is to assure them through the medical memory or whatever ways that you're able to use technology, and to continually remind families and are there with them, and that you are relaying messages to them. And if you're able to video those, showing them that you are doing that can help in alleviate a little bit of that. I can't imagine that it will do a lot of that, but I think really assuring them that we are with them and that they are not alone will help in somewhat ways of preparing them and giving them comfort.
Terry and Dennis, we'd love to hear your thoughts on this.
Thank you both. I think that as this question is very specific to patients and families, I have a couple of thoughts, but what Jennifer and Sedona said is really spot on and is really right there. We don't know how it's going to play out here. But what I'm hearing and what I'm paying attention to is how has this played out in the past, in other traumas, in other disasters, in other times where the normal process of grieving is interrupted. What strikes me as unique about what's going on right now during COVID is that routine and a return to routine are so important for grief. And going back to that new normal, we are already in a different normal. And so the attention to how the new normal of COVID overlaps with the new normal of grief. One thing that I've noticed is the power of the rituals that we are able to provide across the systems. When people share anecdotes, like the one Sedona just talked about, planning a funeral for she's not seen, or a family who she's not necessarily been in physical contact with. What comes to me in all of the stories that I'm hearing are the consistent power of the ritual, because they're in us. These rituals are born in us, and we have lived them. So once we hear those familiar scriptures, once we hear those familiar passages, once we see a routine or a ritual that looks different, it pulls on what we know to be true. So there's grief in it not being the same, but the fact that it's happening, and the fact that it tugs those built-in software, I guess, that we have. I'm struggling for words today. That built-in software that we have is something to lean on in this space. So, Dennis, do you have any further thoughts?
Thank you, Carrie. I was remembering as Carrie was speaking about the topic of rituals, and I agree wholeheartedly that the rituals are very important as our symbols. At CHA, what we recently had a tragic event in our family of workers, of our employees. Our ritual, our normal would be to have a prayer service in our chapel, and for all of us to be together and hug each other and pray together in person. Well, we're all working from home right now, so we weren't able to do that. However, we did put together, and Carrie was a part of it along with Dear Madruni, a virtual prayer service. And was it the same as being together in the chapel? It was not. But was it special? Was it helpful? Absolutely. So I guess I would say there's a lot we cannot do, but what can we do? And we are blessed, and I never thought I'd say this, but we are blessed with all this technology that my 13-year-old niece can navigate better than me. But I will tell you that I have certainly grown to appreciate the ability that we have with Zoom or Microsoft Meetings or FaceTime or whatever it may be to still hold on to some semblance of ritual and symbol. In my experience, I was trained as an ethics consultant and oversaw ethics, and was able, and unfortunately participated in many very difficult end-of-life conversations. They were not always in person. A lot of times in today's mobile society, members of the family were far-flung, different parts of the country or other parts of the world, and could not be there in person. No matter how hard they tried, even if they were on their way, they wouldn't make it in time. So I think that palliative care professionals have had experience in that realm. It's not the preferred way of doing things, but we certainly have learned how to do it more effectively in this mobile society. The last thing I'd say was one of the things that stuck with me when I oversaw palliative care programs was something about what does a dying person want to say? And there's a lot of studies that go into that. And what I took away was there are basically 4 things that someone wants to say at the end of life. And if I get it wrong, please feel free to correct me. But one is, I'm sorry. That's one of the things we want to say is, I'm sorry. The second thing is, I forgive you. The third is, thank you. And the fourth is, I love you. I'm sorry, I forgive you, thank you, and I love you. And if we can find a way, even if it's through technology, virtually, to facilitate somehow for a patient or a family member to express those things, it's not going to be the same as standing at the bedside in person, but we can certainly make an effort to tend to those needs where we are now. That's what I would add. Thank you, Carrie.
Thank you, Dennis and Carrie. And yeah, beautiful reminder, Dennis, of those important words and important things that need to be said and can actually be said in a multitude of ways over a multitude of platforms. So we will navigate to our 4th question. And it looks like after this question, we will be able to have time to address some of the questions coming in from all of you listening today. So as I forecasted, to use Jennifer's words just a moment ago, we also have complicated grief, potential secondary vicarious trauma happening with all of us providing the care. And, many times our different ministries that we work in, we have wonderful and very robust programs of staff support like Schwartz Rounds or Code Lavenders, but many of those forms of staff support aren't available right now because we are intentionally limiting the amount of gathering together closely that we're doing right now. So hearing from all 4 of you, and we'll start again with Jennifer and Sedona, what are some other ways that chaplains and social workers and on the palliative care team can facilitate, bring that creativity to providing support to the staff?
Thank you for this question. I just want to circle back and just let everyone know, just for if they want to get more information on the questions that we discussed just a few minutes ago, is that those are Ira Byock's 4 statements, and you can look those up as well. It's please forgive me, I forgive you, I'm sorry, I love you, and goodbye. So just those are wonderful. Thank you for reminding us about those. But if you want more information, it's Ira Byock. Okay. Staff support. Yes, that's big right now, and it's a topic that we're constantly talking about. How can we support the staff, especially those who are really inundated with being on what we have are COVID floors, and other staff, especially not just the nurses and the physicians, but I'm finding a lot of support is needed for the environmental staff, the people who are cleaning the rooms. They are especially nervous. And so I want to give a big shout out to the people who are cleaning the rooms. They are essential workers right now. And so how can we support them as well? And we have begun doing reflections, interfaith reflections throughout the day that's going through the TV. So it's not only staff patients can view the reflection, but also staff. That's one way we're asking them to take a pause. The other things that we are doing is taking, I do cotton balls with essential oils on it in one of those little plastic jewelry bags, and take them and distribute lavender or peppermint just to help them relax and take a moment. We have set up listening stations for staff where they just need to go and have a moment to have someone listen. So we set up listening stations. And the other thing that we have set up is a spiritual care hotline, so that if somebody wants to speak privately or wants to refer someone, because we know that sometimes physicians will not reach out, or staff just may not feel comfortable, we have a confidential hotline for them as well. So there's you just have to be really creative, besides going to each patient or each staff member and checking in on them and how are you, how is your family, because we know that staff, while many staff feel obligated and want to be there on the floors, they just feel a very deep obligation. Their families are very concerned. And so asking, how is your family? How are your kids? How are you dealing with homeschooling? All those things that are going on. It's not just in the hospital that they're having this distress. It's also knowing that their kids are home, and they're also having to homeschool, and they're having to go home and cook dinner, and they're having to walk in the house and take off their clothes and throw them in the washing machine. Things are not normal. And so being creative in ways to be there with them, that, I like to say we are their gift. We are their, the ears that are going to listen to them. So sometimes, taking the stuff, the lavender, is wonderful, but just being present and being a listening ear is what they need. So on an individual basis, I think is what we're doing to support staff. Jennifer, how about you?
Yeah, Sedona, those are such great recommendations. And what I appreciate is I love how spiritual care attends to all aspects of healing, in addition to kind of the religious aspect, but all the other ways of healing. And I think that it's really important for us to be reminded of that. So thank you for talking about all those other interventions. A couple things that come up for me when I think about care providers, I think about those of us that work in healthcare and are pretty isolated outside of the hospital or outside of our healthcare settings. Right now, it feels like our community is our work partners. There's a lot of us that maybe don't have families at home and are going home to an empty house and things like that. And so also keeping in mind individuals that are truly isolated and thinking about ways that we could reach out to those of us that are experiencing that as well. I think it's really important. I think that, I can speak for my profession as social work. We've had a lot of training about language and modeling, inclusive language, nonviolent communication. And one of the things that I've seen through this pandemic is this shift to language that comes across as very violent, the fight, the front line, like all those types of messages that we're getting. And I think that we need to be reminded of what that actually says about who we are, and that we are not, that we're not feeding into almost like this elitist kind of militaristic messaging that we're getting. And I think that it's really important for us to communicate in ways that are nonviolent and inclusive. And we need to model for our leadership too, because I recognize that leadership often is under this pressure that is very top down right now. And we need to support them too, to make sure that the messaging comes across in a kind, respectful, nonviolent, inclusive way. And so these are opportunities that we can do that might seem subtle and are absolutely more important now than ever in how we think about how we support each other. Anything more you wanted to add, Sedona?
Thank you for bringing that up. I agree wholeheartedly that our languaging is really important, especially now, using words that are gentle and nonviolent. We have words like the what do they call it? It's not the boardroom. It's the room where they're talking about all of this, and there's computers set up, and it looks like a war room. And
the command center.
Yes, the command center. And so, how can we use language that's more inclusive, and while not downplaying the reality and the seriousness of all of this, but to help people, I think it heightens anxiety. And so if we can use language that helps lower the anxiety level, would be helpful.
And before we hand it over to Dennis and Carrie, I just have to say, Jennifer and Sedona, this point is really resonating with our listeners. And a couple things coming in is, so could you give some examples of, if we're trying to avoid the use of the word frontline, for example, what might be some alternative terms? And then secondly, I'll throw it out there too, another person raised the issue of the ambivalence they feel around being designated as a hero.
Mm-hmm.
Yeah, I think I would say, first of all, the New York Times has been covering these ideas in an incredible way. And I don't have the articles to cite specifically, but the past week I've read several articles that are addressing these very concepts and really resonate. So that would be the first. There's no way that I can articulate those questions in the same way. And, just in terms of frontline workers, like I feel like every time I hear that language, or essential, like it creates anxiety, or hero, like all of that, like that is very uncomfortable. And I feel like what we need to do is, like, we are working in the hospital, or we're providing direct patient care, or, like it doesn't, we don't have to have a special designation. We're spiritual care providers, we're social workers, whatever profession you are, we're currently working and we're providing direct patient care. I think that is what we are doing. And so I think it just gets weird when we're in these situations where we start using euphemisms for what we're actually doing. I think we just need to communicate directly about the practice that we have, and not create new ideas that are kind of emotionally laden.
To address the listener who asked about the challenges of being labeled a hero, that is something that we come across, and I have come to the point where I'm okay with it. Not in the sense that I'm a hero. I am not. None of us are. But I've come to know that this is the only way that they know how to say thank you, and they are grateful. So I just say thank you. there's just a point where people don't know how to express their gratitude. And so it's okay. It's okay. That's just my own personal attitude. And I think that, if there were other ways that they could express their gratitude because they're not in a hospital working, they're not in the grocery store, they're not doing whatever it is, they're at home and safe, that's what they feel they need to say. So it's not to diminish what they're saying. It's to accept their gratitude humbly and say thank you. And I appreciate your acknowledgement.
Yeah, thank you for that transparency, Sedona. So with that, we'll call back Dennis and Carrie and kind of revisit this original question. I know we've gotten a little down into the weeds, but from your cross-organizational, system-wide views you have across Catholic healthcare right now, what are you seeing on the horizon as available staff support?
Thank you, Denise. So during this time, CHA has continued to work diligently. You might say I've had more meetings now than I ever did before. Of course, they're virtual Zoom meetings, but we have been making increased effort at communicating with our members, holding conference calls, networking calls. Carrie has had many, I've had many, all of our leaders have. And in those calls, we generally have some questions we're asking. One, how are you doing? And so it allows us to listen to the experiences of the various health systems across the country. And they're all kind of different, especially from a geographic perspective. Two, what are your challenges and how are you addressing them? Many are similar, but again, there are differences around the country. And three, what can we do? What can CHA do to help you, to support you meet some of these challenges? And so we've been collecting lots of information from all the health systems and addressing those needs. One of the first needs that came up was around ethics, which is no surprise. And so we have a wonderful ethics team, Nate Hibner and Brian Kane, and so they've been very active addressing ethical issues. Carrie and Diarmid, Carrie, who's my colleague here, and Diarmid Rooney have worked really hard in addressing prayer resources and other spiritual care resources. And what we're looking at now is pulling together some information about what health systems are doing to address associate needs now. And it's a beautiful response that we have received. Carrie and I could probably go on for another hour just listing them and describing them. But we heard some examples previously. Generally, it's about being present and different ways of being present. 24-hour coverage by chaplains for staff, whether it's in person or virtual or phone calls. Virtual support groups facilitated by psychologists, mental health professionals, and others, recognizing that mental well-being, emotional health is at the core. Very personal things like childcare for workers, folks who don't have time or can't get to a grocery store so they can buy their groceries in the hospital and to get them home with them. Some we've heard of offering assistance to stay in a hotel because you want to be near the hospital or you don't want to go home because you don't want to risk taking the virus home. Many, many examples, pausing for prayer and reflection on a regular basis, meditation. I mean, we could go on and on and on. It's amazing what the systems have done. What I will say is, from a leadership perspective, this is an opportunity for leaders to support these efforts. Again, budgets are moral and ethical documents. And what do we value? And what we value above all else are our staff. And so my hope is, and I know it's true because we see what the systems are doing, there are amazing efforts to address and help staff now and planting seeds and preparing for the future. there will be, as was commented earlier, a great need coming down the road, addressing the long-term effects of this whole experience with staff. So we need to prepare, we need to respond now and then prepare for the future. And a small commercial is that you can expect some resources from CHA specifically addressing these topics in the coming week or so. Carrie?
Yeah, thank you, Dennis. I see in the chat box the pause, breathe, heal was linked there. A quick note about those. Those are under 2 minutes. And there are two aspects of those. It's one, the first set is essentially breath prayer. Breathe in, breathe out with the scripture. And the second half of them are reflection prompts. So in these days of chaos, where have you seen peace? In these days of sadness, where have you found joy? And those are available on our YouTube website as well as a playlist. So feel free to download and share those with your staff and with your members, and use them in those times that you can meet or can push them out to share. When I think about staff support, I think about the second part of this question, or the last two words, right now. What can I do to offer staff support right now? And what's true is that our right nows are very different. Some people's right nows are still, waiting for a surge that might be coming, or a surge that looks different. Some people's right nows are in the middle of this, just the height of their surge. And some people's right now are kind of on the back end. And so what your staff support is going to look like is going to depend on where you are, because each of those stages also correlates to a particular set of feelings, a particular type of grief and anxiety. What I'm hearing from across the systems, I support the spiritual care leaders across the systems, is that there's not only a thinking about what's going on for the next 60 days, but also how does this look for the next 18 months? Where does this look like going forward? And what are those practices that we can push play again immediately if this happens in the fall, or if we get into another place of COVID-19 and a surge? And so keeping track of the surge and what are the staff needs at that time, and what can we just kind of pop right back into. And it's almost, I have a background in education, so I think about when I was a teacher, you're planning what you're going to teach, you're teaching what you taught, and you're grading what you taught. And that ability to be at a system level or at a facility level in all three of those places at one time, no one can bilocate, but thinking about what that might look like. So much of, we had Easter a couple of weeks ago, and I think about how the Holy Week maps out to the COVID-19 epidemic and the coronavirus epidemic as well. And so many of us are in that Saturday where we don't talk about too much of isolation, of being by yourself, of wondering what's going to happen next, of processing all the trauma that just happened. And it's a real Holy Saturday where we don't know that the Easter Bunny is coming tomorrow. We don't know that resurrection is tomorrow. Like, there's no chocolate stashed in our closet. Well, there's a lot of chocolate stashed in our closet. Sorry, guys. But we are in that Holy Saturday of waiting and of being unsure. And so being present where staff are, where your facility is on that journey, I think is the underlying factor to staff support, and thinking about what this looks like further down the road, as then staff are dealing with their kids who might be traumatized in some ways, their older parents. So that's what comes to mind from my way of thinking. And I really appreciated Jennifer and Sedona's conversation about language. I think that could go a long way to mitigating, or at least rounding off, our sense of what we're doing. By and large, this is our vocation. And so we are in the service of our vocation when we're working in these spaces.
Thank you so much. And I am really happy to report that we do have some time for all four of you to address our many, we'll get to at least a few of our audience questions. And for those of you who have not yet typed a question into the questions panel, I would invite you to do that, being aware that we may or may not get to it, but we have several questions around a similar theme, and that theme is, and it applies to all four of you, what are some of the main ways your role has changed in this new time of COVID, and how are you rising to meet that challenge? So I think going with our pattern, I'd like to start with Jennifer and Sedona and hear lots of folks. Of course, we have lots of chaplains and social workers on the line, and they are just wondering practically, like, how is your day different now?
Well, I mean, personally, my practice has changed significantly. I was previously in a role where I was working in an outpatient clinic and providing education to primary care clinics to kind of infuse primary palliative care. Once this started, I shifted and moved pretty quickly into the hospital setting. And I think that there's a couple of things. I felt called to come into the hospital to support my team. I feel like I have an ability to create presence and calm in a time of uncertainty. I feel like I have a pretty stable situation outside of work, which allows me a little bit more space for autonomy and creativity and practice that I think that I can bring. And I think that, social workers in general, a lot of our work historically is care coordination over the phone. And so we actually have a lot of incredible skills that we've utilized in our career of telephonic assessment. And so this is something that social workers have been historically comfortable in engaging on. And so it's not that far of a stretch for us to do initial assessments over the phone and to really try to gauge what pauses mean on the other side when you can't see the nonverbals. So I think for me, this is a time that we as professionals have a time to show a unique skill set that maybe there's a lot of things that spiritual care providers and social workers do that healthcare doesn't understand or doesn't see. And now is the opportunity for us to be like, hey, we've been doing this for decades, and this is how we do it, and this is why we are uniquely trained and suited for this work. So I think that my work has shifted, obviously, to a lot more phone conferences, video conferences, a lot of phone assessment, and really a little bit more process work with my team about how we can support individuals and the folks that care about them a little bit differently.
Jennifer, thank you for that. I just had an aha moment, and I'm chuckling a little bit because you mentioning that, hey, for you social workers, this is a no-brainer. We've been doing phone assessments for forever, and we're used to this type of work. And I'm chuckling because we have a social worker who's new to our team who's been saying, hey, Sedona, you want to make a phone call? And I'm like, no, I don't. I want to see this person. And so, for me, it's like I have to, okay, we'll do this together. And for her, it's a no-brainer. And so I wanted to thank you for that reminder, and that for her, this is very normal. And for me, it is not. So it was a nice chuckle for me. How has my day changed? It has changed in that I'm doing a lot of phone consults and checking in on people and calling spouses and children and saying, I know this is a difficult time for you. This is why I'm calling. And getting their anxiety lower just by hearing, hi, my name is Sedona and I'm a chaplain. This is not an emergency call. Because as soon as they hear the word chaplain, just like when you go into a room and they hear chaplain, sometimes the anxiety raises and they wonder why you're there. And is my loved one dying? So doing it over the phone, adds for me a little bit of a different layer, but a lot of my day is phone calling, checking in on people. And another part of my day is staff support. So that's how it's changed. Not that I wasn't doing and we weren't doing staff support before, but it is very intentional and much more than it was previously because of their stress level as well. So, bedside I am doing with medical memory and other things, but really it's a lot of phone and staff support.
Great. Thank you both. How about Dennis Terry, from your organizational and leadership point of view, how has your day-to-day changed?
Well, we have been grounded for a while. I haven't been grounded since I was a teenager, but we've been grounded. So we no travel. As you know, CHA sponsors and leads quite a few gatherings and meetings throughout the year. So we have put on pause or canceled or rescheduled a lot of events, as many other organizations are doing. On a positive note, I will say that we have an awesome vice president that leads our team, Brian Smith, and he's made an effort so that we have a touch base meeting every day. It's a half an hour. It's a Zoom call. And in many ways, we're communicating with each other and seeing each other, though not in person, and checking in with each other more than we ever have. And that has been very much a grounding opportunity where we maintain a cohesiveness as a team. While we're not in the facilities dealing directly with patients, we are reaching out more than ever and holding more and more conversations with members throughout the country to see how they're doing and to see what they need. So we're very busy, just a different method. But again, I think staying connected as a team, utilizing technology, has made a huge difference for us.
Yeah, Dennis and I are on the same team, so a lot of the things that he said are true for me as well. How my day looks different from a super pragmatic place. There might be some other parents of young children here on this call, so my day looks a little bit like a lot of code switching between mom's brain and work brain, and being okay with how much I can give to either of those things. I think there's an anxiety that comes. I would be speaking to any from the place of your at-home staff, from the place of your support staff, and anxiety that comes from the unknown is palpable here working at home too. The feeling of isolation and am I doing enough? Want to be more. That certainly it's a guilt of being not in the facility. So for those that have been sent home, there's that. Am I doing my best to support those who are doing their best in frontline care, in direct patient care, Jennifer? And so there's a lot more reaching out, and the conversations may not be as in depth, but hey, I know that coworker also has 2 small kids. I'm going to reach out to them, or I know that person was worried about their mom, so I'm going to reach out to them as well. So giving myself the permission to balance both that professional and personal, and recognizing what's different. And I was on a call with a bunch of people, and my son is 5, and he was swinging around a toy in the back, and someone chatted me, and he's like, "Your son is running in circles in the back," and I just like, that's about right. Because that's where we are, and that's okay. So really reassessing standards and figuring out balance, and from CHA's perspective, wanting to make sure that we're touching in with our members and hearing what you all need so we can support you. It's a great question. Good cue.
Thank you so much. Thank you for the entire presentation. Just now to each of you, all 4 of you, thank you for your transparency again and vulnerability, and letting us in behind the curtain of your lives. I think that's one of the challenge of this, is that we feel separate, but in some ways we're actually more connected than ever before. And you all have helped us connect with our common shared experience today. And thank you for the wisdom that you all have shared with us from the abundance of your experience in the field. And I'm just very, very grateful for this presentation. And I would like to thank all of you who took the time to attend this event today. We are very grateful for your support for these webinars throughout this 5th of the 5-part webinar series. And as the webinar ends, I'd like to invite you to complete the program evaluation that will come up on your screen. We use that, we value your feedback, we use it to plan future webinars. And so next week, we are going to be passing the baton to some of our colleagues and partners in the field with a series of additional webinars. And as that next slide comes up, I will describe them to you. So there is an abundance of offerings coming from our partners in the field. From Jennifer's neck of the woods, her colleagues in Oregon have created and crafted what will turn out to be an amazing free 1-hour communication skills training. It's based on the Vital Talk communication skills for palliative care and difficult conversations. Those, as I said, are going to be weekly. They're going to be directed to different, actually non-palliative care provider audiences. So if you know folks in your ministry settings who work in outpatient care and they want to learn more about how to have these difficult conversations, or they work in acute care, there will also be sessions for folks who work in the ICU, the emergency department. So we highly recommend those to you. As Dennis referenced earlier, the Catholic Health Association, in partnership with Georgetown University, is offering an ongoing series, taking a really deep dive into some of the specific and technical and challenging bioethical questions that have arisen in the context of the COVID pandemic. So those are ongoing, also complimentary. The registration link is there. And then lastly, our partners at the California State University Shiley Institute for Palliative Care are also offering a Zoom open forum webinars. Those happen, one is happening today shortly, but they are ongoing on a week-by-week basis. And they are specifically gatherings to talk about how to adapt and use telemedicine tools, especially if you've never done it before, and how to conduct a really effective virtual patient visit. So we recommend all 3 of those things of our partners and colleagues in the field to you as you continue to navigate the new challenges, the new horizons, the new vistas opening before us. And with that, I would just like to remind you all, as you heard Brianne say in the beginning, this webinar was recorded, and tomorrow you will receive an email with a link to the recording. And in that email, we will also include the links that we have been posting in the chat panel that link to the various resources mentioned by our panelists. So again, thank you, Carrie, Dennis, Sedona, and Jennifer, again, for giving us your time and your kindness and your compassion. And thank you, everyone who joined us today. Have a wonderful day.